very much again. As you know, the origin of the anorectal abscess is not completely known. However, the most common accepted theory is the cryptoglandular origin. The other possibility is when the bacteria is located in the skin, penetrate the skin barrier and cause the abscess. The most common, as I said, is the cryptoglandular, and we know predisposing factors like obesity, immunosuppression, and diabetes. It's very important to know the location of this anorectal abscess, and basically we have ischiorectal location is the most common in the right or left position, then the perianal or superficial abscess, and the intersphincteric, and finally the supraelevator abscess. This type of abscess usually secondary to intra-abdominal pathology like complicated diverticulitis or inflammatory pelvic disease. We can divide the stage of the disease in the acute phase, that means the abscess, and then the chronic phase when the patient development of fistula tract. By definition, the fistula is the communication between one organ with mucosa and the skin. And particularly in the anorectal fistula, we can have a simple fistula with short tract, or very complex fistula with 2 or more holes that make more difficult the surgical management. Why do the drainage and fistulotomy? Well, this paper shows a prospective non-randomized study with 165 patients treated between 2005 and December 2010. 102 patients were eligible for this study. 52 were treated by simple drainage and 50 with drainage and fistulotomy. And the results show very high rate of recurrence of the fistula, almost 90%, with the patient treated just with surgical drainage of the abscess versus very low 4.8 rate of fistula tract formation after the surgery with both procedures. However, this study also showed a high risk of fecal incontinence in the group underwent to fistulotomy, 5 versus 1%. This is not significant difference, however, it's higher in the group underwent to fistulotomy. The other significant findings confirm that the fistulotomy is an effective and safe treatment for the abscess with good long-term results. But we need to consider a high fistula where the fistulotomy is associated with high risk of fecal incontinence. These other papers show good results with the treatment of drainage and fistulotomy, and they analyze the quality of life and the recurrence of the fistula, sending a questionnaire 1 year after the treatment, and the patient returned the questionnaire in 76% of the patients. In this study, 39 patients, that means 34%, experienced some grade of incontinence during the follow-up of almost 8 years after the surgery. So surgical fistulotomy, multiple abscess, and high transsphincteric fistula are associated with fecal incontinence. The fecal incontinence was evaluated with the Westneck or Cleveland score, and the incontinence was worse after surgery for complex fistula. So we need to take care in patients with 2 or more fistula tract or complex fistula. So in conclusion of this study, the surgical fistulotomy is the strongest risk factor for fecal incontinence, and they recommend take care of this type of patient and increase the sphincter sparing procedure using the setome, for example. So for this reason, we analyze in retrospective fashion our data, considering that more of the patient has a cryptoglandular origin of the abscess, different forms of treatment as antibiotics, needle aspiration, or local drainage is associated with high rate or recurrence or development of fistula, and also because there are few literature information regarding the one-stage management of this disease. So we analyzed 90 cases in retrospective fashion with focus in the recurrence and development of fistula tract. During the period to June 2011 to April 2015, we had an average of age of 39 years with a range between 19 to 73. Most frequent location was ischiorectal location, almost the half of the patient, followed by posterior, anterior, and 3% horse shows location. Most of the patients were female, male sex, and the hospital stage, surgical bleeding, time of healing, recurrence was analyzed. So this slide shows a predominance of male sex. The location more frequent is ischiorectal, followed with posterior, anterior, and then horseshoe location. The surgical time mean almost 20 minutes. All the patients were in the hospital just 1 day, and the recurrence rate is just 2%. Only 2 patients developed a fistula in the follow-up. So this study showed when we perform both procedures, drainage and fistulotomy located in the internal hub, the origin of the fistula, the incidence is very low, only 2%, and we recommend this approach for cryptoglandular abscess because decrease significantly the need of another surgery in the future. Thank you very much.